Hello everyone, welcome to Health Global. Today on the occasion of National Cancer Awareness Day, we have with us Dr. Ashu Abhishek to speak on the subject of radio-oncology and importance of early detection of cancer. Dr. Ashu Abhishek is a leading radiation oncologist and head of GI cancer management team at Apollo Proton Cancer Center, Chennai. With an extensive experience at Fortis, Medanta, Artemis, he now specializes in precision radiotherapy and proton therapy for GI cancers. Let's deep dive into the subject. I am Saimik and you're watching. Let me begin by asking you, what inspired you to pursue a specialization in radiation oncology?
See, actually, when I did my MBBS, at that time, probably we never had oncology in curriculum,
Sure.
right? So I think at that point of time, and especially at that moment, oncology was something which was still new in the way that there were cancers, but actually oncology was also always looked at something which is very, desperate. It's a social stigma. People don't come out. They're not aware. And I think it's unfortunate that even after 30 years, we have
True.
improved for sure. But even then, we used to still have late stages coming to us, and that is the status right now also. So it was all about palliation. It's all about, so people, to be very frank, I wanted to be ortho at that time, right? Because
Okay.
somehow orthopedics really, excited me. But then it's very unfortunate. A batchmate of mine from plus two had a blood cancer that is called as
Okay.
CML, right? So CML nowadays it's something like it's a routine treatment and patients survive for long and long. But at that time, that was a moment when the drug that is called as imatinib, which is so common and frequent now, wasn't even available in India. And
Okay.
then we actually had to get it through US. It came via Bangalore, via Hyderabad, then reached Delhi. We did so much and still we lost him. So I think I'll say that was my first exposure to oncology per se, and someone so close. You see him,
Definitely.
suffering from cancer, and that is the time there and now. That was one case I had someone close by, and then even if I talk about MBBS, where I used to get one call in 3 months, and now it is like every day I get three calls that someone or else has a cancer. So that is definitely oncology has, is now a total, what I say, epidemic per se. But at that point, there was so much to evolve, so much to research, so much to see, and there was a fight to find an answer to cancer. So probably maybe that excited me, and that's how I chose oncology.
So you mentioned about it is a very frequent nowadays that you come across patients who have cancer as compared to earlier days. Is it people were not ready to come out and talk to them, their family, or is it like there is some lifestyle changes that has increased this phenomenon?
It's a mix of both, I'll say for sure,
Sure,
because we still are the same human beings, right? But obviously, we are more aware. I'll put the positive thing first. So we are more aware about cancer.
sure.
People know that it can be treated. People come out, they get diagnosed, and that's how we have more incidence of cancer, more detection of cancer. But at the same time, when I say that we are the same humans, 30 years back, when I used to get one call in a month versus now almost a call in a week or a day, it all depends on our urbanization, our lifestyle, our food habits, stress factors. And that is possibly one of the reasons that the incidence of cancer as such has increased because now we
Okay,
are no more, having pure natural things. Our food habits have changed, pollution, and much of it is not in your control. You can't control air, you can't control water, you can't control what you're
true.
eating, right? So that is the major concern, I would say. So both of them put together, it's more detection, yes. At the same time, definitely the incidence is increased, and that we see probably when we were students in many of the cancers, it was always a cancer of old age, 45, 50, and beyond. The
Okay,
same cancers are now happening at 25 and 30. So there
okay,
is definitely a change that has happened in
true.
environment and which is causing more cancers to happen now.
Okay, what type of cancers do you frequently come across for treatment?
See, this is a question which has to be answered because it all depends. So there are, if you ask me as a doctor, one, this question should be what is the more prevalent cases in India, say
Sure,
for example.
sure,
At the same time, if you'll ask me what cancer I see, there are two different questions. So
sure.
I'll put the first thing first. For a common public, we should know. Most common cancers in head and neck, otherwise, for men will be head and neck cancers. They are most frequent in India. Cervical cancers, breast cancers, lung cancers, these are very frequent, mostly related to tobacco, smoking, pollution. That is
Okay.
one reason. When you go to, and when you ask me what I see, that all depends on which hospital I'm working in, what
Sure.
specialty I am in. So I'm a GI radiation oncologist. So obviously I'll see more GI cancers. That doesn't mean that the GI cancer incidence is more. But
Definitely.
if you ask in general, in public, it's mostly head and neck cancer, breast cancer, lung cancer, which are the three most common cancers we get across.
What is the importance of early detection? How much it is helpful?
See, there cannot be anything better. When we say cancer treatment, the first step always is early detection. See,
Sure.
the advancement till very late, we always thought that cancer we cannot win over it because most of the cancer, especially what we are facing, is late cancers. And whatever you do, it's more about getting quality of life, improving it, adding some life, some palliation. But at the same time, now we are in a phase where we talk about cancer cure, we talk about survivors, and that has all been possible because if you can detect a cancer early, you can treat it in a proper way. So that is how prevention and early detection, these are the most important tools when you talk about cancer treatment.
How do you stay updated with the latest advancement in cancer treatment?
I'll again break into two. I think a decade earlier, it was more about what we study. So we
Sure.
obviously have to be updated. And that's how most of my friends say that what are you still doing at 45, 47, we still have to study a lot. While the others, they have just studied till like graduation and it's more about their work and skill that they're doing. So jokes apart, we do have to be updated because oncology is something that is changing every year, every couple of years,
Okay.
every 5 years,
Okay.
there's a new thing which is coming up. So obviously it is done through attending conferences, having seminars, having discussion amongst our peers, journals. So this is one part of it. This is how the classic teaching happens. Most importantly, now in the last decade or so, we learn a lot from our patients because
Okay.
and
Okay.
it is good to treat patients who are learned, who are intellectual, because ultimately it's the patient involvement which is so much necessary. I don't appreciate those Google doctors and Google patients per
Of
se,
course.
but yes, definitely the patients are more aware. And obviously, if you're suffering with a disease, you like to find out what is the best that can happen to me. And I'll particularly say this: it's not the fate of the patient that which doctor he lands to. If a doctor doesn't know that there is a second category or third category treatment, it is the doctor's fault. It's not the patient's fault. So we
True.
have to be updated that number one for this particular cancer, what is the best treatment? It's not about what you have. It's about what and how best the cancer can be treated.
Okay.
What facility you have as an institution, as a specialty, you can offer that. But the patient has all the more rights to know how best this cancer can be treated, where best he can take this therapy, and then you guide him that what best can be done in the practical situations.
Where does India stand in terms of cancer treatment as compared to the entire world?
I'll say in the last decade or so, India is at par, 100%. There's no
Sure.
doubt about it. See, I'll tell you, it all started probably we as Indians were much higher in healthcare because Sushruta surgery came from India. It has been so nicely described. Somehow down the line, whatever happened in our like olden times, we lost that art, and probably the Western people, they because of advancement economy, they exceeded us. But
True.
whatever said and done now, because of so much of burden of cancer, so much of population around, so much of need, obviously there is an intent of people, doctors, and also the administration, because a patient having a cancer in India is nowhere different from Africa or Europe or US. So they deserve the right therapy. And right now, I think we may be, say, for example, I'm a radiation oncologist, and if there's a new technology or there's a new machine that is launched in US or Europe, it might just take 15 days or a month maximum, and then
Sure.
India can have it. So it's all about your intent. Obviously, there is finance involved in that. That's a different question altogether. But availability and access to treatment is at par at most of the countries, and India is definitely, and that's how you see so much of medical tourism happening. Because not
True.
only we are treating our patients, we are also treating patients across boundaries,
Very true.
and that is what the whole intent of health for one means.
I always wondered how difficult it must be for a doctor to break the bad news. of cancer? What are the challenges? How do you do it?
See, I'll tell you a very common example. Most of the patients who come to us, it's not only the patient, there will be few relatives who will come along, right? And there are
Sure.
so many occasions where you see a patient who comes to you directly and asks direct questions, but most of the time it is the attendants, and with all their good faith, they say, my father, my brother, my uncle doesn't know anything, don't tell him anything. He'll be totally shattered, which is right in a way because the first question that comes to you is why me? Why me and what after this, right? So this is a very difficult question for anyone to answer. And there are so many uncertainties because in medical science, it's never one plus one is two. So you know what the disease is, you know what the treatment is. Even then, you can't say that what will happen to you. You can always tell him so many stats, so many numbers, but what will happen to me is the question that the patient asks. And even with all the information that you have, you can never answer that question, right? So that way, you always have to speak both the positive at the same time negative side also of it. But it is always better. What I feel is to go very slow because each and every information that you pass on, because the patient looks at you with a lot of hope.
True.
So you cannot say if a patient asks you directly, because mostly in a multi-speciality hospital, many of the patients already come to you with a diagnosis. And me being a super specialty, so it's always diagnosed. They already know what they have, and they come to us for opinion. So in a way, for me, at times it is easier because they know that what they have. The next challenge is how best I can treat him. So that is the next sort of a challenge where even if you know that it is a stage four cancer, bad cancer, but you have to give him that hope because it's not that a stage four cancer means death sentence for everyone.
Okay.
It still will have different cohorts. When we label a cancer as stage four, it will still have different cohorts where some people will really do bad, but then there are cohorts within that patient who will still do better. You cannot, on the very first day, write off a patient saying that stage four, no treatment, just be at home. With the hope that out of those 100 patients, 20 patients did good, you are that patient. There is a hope that I can treat you. You can cooperate with your treatment. You can be mentally, physically, and emotionally, supportive. And then if you are on the positive side, definitely we offer 100 to all. But there are patients who have 75% response. There are patients who receive 125% also of the response.
Okay.
That means patients who are more positive, they are more looking forward that yes, I have to get better, they also do better. So there is some part of internal healing that I always believe that is there. Because see how cancer develops from 1 to 2, 2 to 4, 4 to 8. That is the
Sure.
doubling of cancer cells. When you give a therapy, it becomes from 4 to 2, 2 to 1, and then half, then 0.25. So technically it is never zero. The idea is to bring down the cancer to such a level that it becomes a chronic disease where your body immunity can take over. So
Okay.
that is the point where your internal healing, your positive attitude, your lifestyle helps to maintain what we have achieved through therapies. If the patient is already psychologically broken down on the very first instance, he will never put that effort to be better. You have to have at least 3 months or 6 months of therapy to know and understand that biologically is this patient really bad or he can do better. So that is how we always start with a positive note saying that yes, I know that there is something bad, but at the same time there is a problem, but there are multiple solutions to it. We are
Okay.
just trying to figure out what is the best solution for you. It might be very easy to put this way right now, but then obviously there are situations where patients break down, where the family breaks down, so it's always easy to say that nothing has happened. That is the worst part of the discussion. Probably you should always say, I can understand that yes, there is a problem for sure. But then once you tell them that there is hope, it makes a lot of sense to them. So yes, it is a challenging part for sure. And there are different people who deal with different ways to it. But ultimately, people do understand and then they do come back to the fact that yes, they have something, but at the same time, there is treatment possibilities for the same disease.
Okay. You mentioned that it is never zero. It comes down to say 0.25 or whatever. So this is what a relapse is. That's what we hear.
I'll tell you, it's a very common thing. See, if you go to a hotel, you pay for a service, then we
Sure.
always say that I have paid so much, I got the service. The same concept. It's unfortunate that in healthcare also, because of privatization, so many good things have happened. I am a
True.
radiation oncologist. If there would have been privatization, probably India wouldn't have these latest machines, right? But then once you talk about privatization, there is a cost added to it, right? Once there is a cost added to it, people say that I paid this much, but still I'm not cured. I have given so much of a time, still the disease is not gone. So that is the problem with cancer. Main intent why we treat cancer is one, it is locally growing. Secondly, you may reach to a point where your PET scans or MRI or imaging doesn't show a disease, but at a microscopic level, it is still there. That is the
Sure.
difference between a bacterial infection, where there is a bacteria from outside which has come in, while a cancer, which is not something which has come from outside. It is your own body cell that is now rapidly growing uncontrolled. So when
Okay.
you try to kill cancer or treat cancer, you are actually destroying your own cells, which have gone bad. And once they come to a point that they are controlled, they cannot be seen on imaging, but they are still there. And that's how we say that there's always a possibility of a cancer recurrence. Recurrence rates will be more in stage 3, stage 4, much lesser in stage 1. So we are all as good as completely cure, but we always say that it is locally controlled. And that
Okay.
is how follow-ups are mandatory, they are important, and that is how surveillance has so much role to play in it, even if a patient is so-called controlled or cured of cancer.
Are you involved in any kind of clinical trial or research?
So basically, in every form, whatever patients we treat, so it depends on which institution you are from. So
Sure.
most of the government institutions will have trials for sure. But at the same time, once you're in a private institute, because the patients are paying for their treatment, so
Hmm.
you may not be actively doing a trial because trial at the same time, because there are two ways to look at it. A trial will also mean that you are using a patient to research for something. We are
Yes.
here because there were so many trials that happened in the past. So it all depends that how much is the consent and the comfort of the patient
Okay.
to go for a therapy which is still not ensuring or which is still not, approved for a particular therapy. We have to hit and try a drug, try a technique, and then say that yes, it is good or bad. We don't do X amount of X therapy for a patient because in the trials it showed that it was bad. But just consider a patient for whom that X trial or X treatment was done. So in a private institute, sometimes it gets difficult to do a trial where it's actually a trial, so-called. But then we have so many other observational studies because obviously we ultimately learn from our patients. So what we do is, for example, I'm sitting in a center which is having a proton, which is the first proton machine of India. So every patient that I treat has to be reported, has to be documented because that's how we learn and we teach the people that how a proton or how a new technique is helping a cancer and which other patients will be benefited. So this is a part of a trial, this is a part of a research which contributes to healthcare and the management of such patients.
We also keep on hearing about proton therapy, which you just mentioned. So, can you please tell us more about it? What is it all about? And how it is contributing?
Yeah, so I'll take you a step back because I'm sure there may be many, general public. So before
Sure.
jumping onto proton, when we say cancer, there are different ways of dealing with cancers. There are three major pillars of cancer therapy, local and systemic. So when a disease is limited, we do local therapies. Now, local therapy primarily can be surgery, that is physical removal, or radiation, that is we try to destroy the cells by using beams like light, X-ray, photons. And
Okay.
similarly, if the disease is widespread, we use medical management that can be chemo, hormone, immuno, and so forth. When we talk about radiation, so radiation is which fraternity I belong to. Most of the radiation in general is X-rays, the same X-ray that is used in a X-ray of a chest or a CT scan that are photons. But then when you use heavy particles, these are called as protons. So
Okay.
proton is nothing but a refined form of radiation machine. So when we were students, there were cobalt machines. So cobalt is a very natural source of radioactivity, which produces photon, and they were used for cancer therapy. No doubt, 30 years, 40 years back, also patients were treated, but then there were side effects because you
Okay.
didn't have technologies to control the X-ray to the cancer and save the collateral structures. So by using different modalities, angles, imaging, technique, you try to focus more and more to the tumor and save the normal structures. And that is how the evolution of radiation happened. Now, proton is similar. It has imaging, it has better techniques to deliver it precisely. But at the same time, the particle by which you are treating, which basically is a photon in a normal radiation, which has an exit dose, that means there is low dose going to the surrounding structures. A classic definition of proton is like a waterfall. So it has a
Sure.
waterfall effect where the dose suddenly drops. And we say that there is no exit dose because of which you can treat the tumor better and you can save the surrounding structures. So that is how it is still. So some people do inquire and send mail to us. They are metastatic disease, stage 4 disease, and they feel that possibly proton is the fourth type of cancer therapy and probably can cure patients who have
Okay.
failed on chemo. But that they should understand ultimately, we don't decide proton first. We decide whether this patient needs radiation, and then we decide between photon and proton. In cases where giving photon is challenging, in cases where some patients photon is contraindicated or difficult to deliver, their proton can have a much better response because it saves better, it can treat better. So that's how the difference between photon and a proton is.
Okay, so you mentioned about 30 years back, radiation was also there. If I ask you the evolution, would you consider it as a leap and bound in terms of evolution, particularly when we are talking about radiation therapy?
100%. See, everything has improved. See, the thing is, even if you talk about surgery, so I'll take example of surgery because people know surgery much better. So
Sure.
earlier it was all open surgery with high risk of post-op mortality. But then people went on to laparoscopy. Now people have gone to robotic. So why
Okay.
this evolution? Because you have better control on the surgical skills. The post-op stay is better, blood loss is better, and mortality is lesser. So same thing happens in radiation. Till proton and heavy particles came in, the basic source of radiation was still the same. The difference happened was it was a natural source versus a electricity generated controlled radiation which was given through linear accelerators. And then you had
Okay.
different X-ray coming in, CT scan, and all those things which helped in delivery of radiation better. And now we have moved forward in changing the source of radiation to proton. So that is how with evolution, we always try to maximize the tumor control and minimize the collateral damage. And that's how you get the therapeutic window, which improves every therapy that you offer.
Your expertise lies in the treatment of GI tumors. So, can you explain to our viewers more on that, please?
So when you say GI, so basically what happens is before coming to Chennai, I was in various hospitals in Gurgaon. So
Sure.
in general, at that place, I am a radiation oncologist. So we used to treat everything from brain to prostate and legs and everything, all cancers. So that is how we all have been taught in graduation, and that's how many people do it. But somehow I really appreciate the present center where I work in because there's so much of evolution happening. How we treat here is we have cancer-based teams or
Okay.
CNTs. So basically, there is a team of head and neck cancer. There is a team of nervous system. There is a team of lung cancer. Similarly, I treat GI cancer. So when I say GI, that is gastrointestinal tumors. It starts right from your food pipe, stomach, then it goes to the gallbladder, liver, pancreas, large colon, rectum, that is the lower part of the gastrointestinal tract, and finally anal cancer. So these are the whole gastrointestinal tract where different type of cancers happen. So I specialize in treating these GI cancers. Now again, like all cancers, GI cancers can be treated with surgery, with medical management, chemotherapy, and radiation. So we have a team of GI specialists who have surgeons, medical oncologists, and I look after the radiation part of GI cancer.
Any particular reason you joined Apollo Proton Cancer Center in Chennai? Apart from not there's so many other options also.
So one of the basic reason for me coming to here was obviously proton because proton came. So obviously when we were students, we had always heard about there's a machine which is proton because as a radiation oncologist, you always like to improvise. You want to treat your patient better, minimize the side effect. But a surgeon can have a good skill, but he has to have a good OT. He has to have a good post-op care. Similarly, in radiation oncology, we are so much machine dependent, computer dependent, technology dependent that even if you have a knowledge, you cannot deliver what you know if you don't have a machine. So that was the reason to move all the way from Gurgaon to Chennai because of this machine. Because the first proton that came in Chennai was in 2019. And in fact, at that time, that was the first machine in whole Southeast Asia. Before that, patient used to travel outside India, Europe, US to get the same therapy and pay almost four, five, six times the cost. But fortunately, now we have it in India. So this is obviously one reason. At that time, when I joined, there were three doctors. I was the fourth one in the country to be working on protons. Obviously, it was something very good. Most importantly, because I'm so interested in GI cancers. So in fact, I really like treating liver. Liver is a very, I really like it because I still remember one of the conferences where I was talking to my mentor. It was Dr. Laura Dawson from Princess Margaret, Canada. So I just spoke to her. She's supposed to be the godmother of liver cancer treatment. She's a radiation oncologist.
Wow.
So I was just asking very early in my life that I have so many interests. What should I take up? So she said, pick up a cancer which has so much to evolve. Radiation till 10, 15 years was not defined in liver cancers. People only knew about some radiofrequency ablation, some surgeries. That is it. And some palliative chemo, even chemo was not involved a decade earlier. But now things have evolved so much, and then radiation forms a very essential component of liver cancer management nowadays. And that is where proton, and that is how in proton liver cancer treatment is the category one indication. So different categories. So obviously just because we have proton doesn't mean we treat everything. We can treat, definitely all radiation patients can be taken on proton, but you have to be selective that which are the best patients which will benefit the most. So liver cancer, esophagus, these are two major indications where proton helps in GI cancer, and that is how I am.
Okay. I have watched this series called Doctor House in Netflix. It's about, I'm sure you must have watched it. So it's a series about doctors, and what we have seen is like it's a out and out stressful kind of a job with lot of challenges. So my question to you is like, how do you keep yourself sane in a situation like this?
See, this is very important because a good doctor is someone who can, not fix to his emotions. See, the point is, I see a patient now who has done very bad. He has failed treatments and now he's terminal. So the whole environment in the room with the family is very bad. You feel bad because you get connected to your patients.
True.
Half an hour consultation, patient goes back. Then 10 minutes later, the new patients come in. He's a young boy, just now suffered. He's a player and just now suffered with cancer. Now I cannot carry my emotions from my previous patient to him. It is not his fault that what I underwent in the last hour or what I was discussing to the last patient. So every hour, every consult, you start fresh with a fresh mood, with a smile on your face, because at least your doctor should be someone who should be to someone whom you want to talk to, you want to open. So
Very
that's
true.
what we say. Your lawyer and your doctor are the ones whom you have to disclose everything inside out. So just imagine a person who comes to you with all the faith. You cannot have a blunt face in front of him so that he's so scared of even talking to you. Right. So the first thing, and I think it is again an individual choice. Many doctors don't share their numbers. I do like sharing my numbers, and that's how I get calls at 1 o'clock, 2 o'clock at night from national and international patients because at times it is important because the patient may be in trouble. So just trying to say there's so much things happening and this is set aside what happens in your personal life. Just because I'm a doctor doesn't mean I have a personal life. You have family, you have kids, you have issues there, financial, emotional, family, everything. So I think it is very difficult. Obviously, you have to be much more stable. I think meditation, some sort of interest or hobby is important. Very strangely for me, my hobby is totally different. So I like long running. I'm
Okay.
into ultras. So I run 50, 100, 120, 200 kilometers in a stretch. So that is called as ultra running.
Wow.
And when I
Amazing.
run, and I basically like running solo. I think that is my me time. So after five, so most of the people who start running, they say after 5 kilometers, they have a shin pain, they have bone pain. We also, whenever, if I'm doing a 50 kilometer, first 5 kilometers is the same feeling to everyone. But then after you reach 5 or 10, then you go into a zone that where you're floating. You're just running on a highway. I don't use music. I just pick up a topic, start thinking over it, and then I see my watch 2 hours have gone. I have done 20 kilometers, I have done 15 kilometers. So running is my me time. It is my sort of a meditation. But set aside, people use swimming, people use music.
True.
There's so many things. So you have to have a hobby. You have to have your me time so that it's about, resetting. yourself again back to zero so that you can start afresh. So that is most important for anyone, be it medicine, be it engineer, be it you, be it anyone else in your office. We all have to reset every morning we get up, a fresh start. Every day is a new day for us. We have to have a fresh start, only then we'll have a fruitful day for us.
What new technologies or treatment protocols are you most excited about?
See, I think obviously I'm a radiation oncologist, so everything that will excite me is radiation. But then if I say oncology per se, see, ultimately, radiation and surgery are important therapies. They are local therapies, which is the essential core of oncology because it treats the source of the disease. But unfortunately, most of the cancer patients they metastasize, they spread to the other parts, and that is what decides the survival of the patient. So I'm really happy the way systemic therapy has progressed. Systemic means chemo and immunotherapy. So I'll give you an example. When we were students around 25, 30 years back, lung cancer meant 3 months, 6 months maximum. But now we get to see cancer survivors, lung cancer patients, stage 3, stage 4, who are seeing 3 years, 5 years, even beyond that. And what we say is if you are able to give another 2 to 3 years of survival to a patient, even if he's advanced stage, stage 3, stage 4, second year, third year on, there may be new medicines, new drugs which are coming up, which can be added to his therapy further. So it's not that surgery radiation is not important, but I'm really excited about how things are moving. And earlier it is swelling in the tongue, tongue cancer. That was how cancer was defined. Then
Okay.
next era came where tongue cancer or maybe a GI cancer. So it is adeno or squamous. So these are histology types. Till very late 20, 30 years, we were stuck to that. Organ and histology. That is all, nothing else. But now we are working at a target level, at a gene level, at a driver mutation level. So now there are cancers, there are techniques where we can find out the driver mutation of that particular cancer, and then you can give a targeted therapy against that. That is how it is making things change so much. We're having more cancer survivors, more survival, more better results in all the cancers that we are treating. So that is how cancer is moving forward, and 100% we are much, much far better now, and 100% will be much, much superior in the times to come when it comes to cancer treatment.
Okay. Any message to our viewers in terms of do's and don't, which they can avoid to refrain from getting this disease?
First thing, don't do Google, number one. Secondly, see, the thing is, ultimately, you have to understand anyone who is surviving is bound to have disease, right? Cancer is just one part of it.
Sure.
It can be a heart disease, it can be something else. But especially in oncology, the problem is it takes away your life too soon if you don't detect it early. Any abnormal symptom that you find out. See, the problem with oncology is if I have a gastritis, I cannot label myself or get myself tested for stomach cancer or esophageal cancer. So all general symptoms mean general diseases, simple diseases only. Go to your physician, get yourself treated. But if it is persisting for more than 2 to 3 weeks, there is weight loss, there is some abnormal swelling, some abnormal symptoms like bleeding, breathlessness, seizures, then there is something wrong. And it's absolutely fine because in general medicine, sometimes general physicians they are not aware about how oncology can behave. But at least if they can raise an alarm sign that this is something that they cannot treat, that is where you should act fast. Get yourself diagnosed. If you can detect yourself early, cancer is curable, cancer is treatable.
Okay, my last question to you. What would be your word of advice to the medical aspirants who would like to pursue oncology as their stream?
First advice will be you can change your stream. Maybe go to jokes apart. See, the thing is, you have to be dedicated because there's a lot of struggle in medicine, to be very frank, right? If you're an MBBS student or you're just a class 12th pass out, most of your friends will complete their studies in 5 to 7 years. They'll be earning like anything, but then you'll be still slogging for another 10 to 12 years. And even once you have completed your MBBS, there is a second fight for MD. Then there is third fight for super specialization. Then you become a senior resident who's like a first year facha of any college, right? So that is how things are. But then at the same time, if you get connected to your patients, if you are really into Seeing smiling faces after whatever you have done to them, medicine is the field to be. There will be 100% lot of disappointments. There is death, there is morbidity, there is pain, there's a lot of negativity all around. But you work for that one positive smile that you get out of the patients from the effort that you put in, right? So only thing I can say is most of the people they aspire to become ortho or oncologist, ophthalmologist, so many things. But what they fail to understand is your basic MBBS and the first years of medicine, your internship for 1 year is most important. That is where you learn your clinics. That is where you learn to speak to your patient. That is where you learn communication. Because communication is the key in any health services, any sort of this thing. So until unless you can't connect to your patient, until you cannot speak to your patient properly, you are gone. You cannot ever be a good doctor. So that empathy, that connectivity to the patient is important. You may not, compete for exams first, second. So that is very common in MBBS and MD. You sit for first, second, third year. Those 1 or 2 years never matter. Don't get disappointed. If you're really into it, those 1, 2, 3, 4 years will never matter. Today, when we go out with our friends who are colleagues, we never ask them which year MBBS you passed out. There were some of my batch, there were some seniors to me, some juniors to me. I did mine in second attempt. So all those things don't matter. Ultimately, how good you are a doctor and what you give to your patient. That is what all matters. So you have to be dedicated. Only then you can be a good doctor. Some people use MBBS as a route to MBA and IPS and this thing. So that is also one thing. But if you really want to be a doctor, you have to be dedicated. Please don't spoil the seat of MBBS.
Dr. Abhishek, thank you so much. It was very insightful. I'm sure it has created lot of insightful information for our viewers itself. It was lovely talking to you. Thank you so much for participating in creating awareness campaign for us. Thank you so much for your time. Lovely talking to you.
Thank you. Thank you.
Thank you so much.